Hello, my name is Alyssa Steiny, and I'm a PGY1 pharmacy resident at Poudre Valley Hospital. Today I'll be discussing with you fostamatinib or Tavalisse and its role in the treatment of immune thrombocytopenia. We'll look at ITP as an overview and look at its drug management. I have no listed financial interests or any arrangements that would be considered a conflict of interest. The learning objectives are here for your review, but we'll discuss the pathophysiology and clinical characteristics of ITP. We'll also identify appropriate laboratory tests for the diagnosis of ITP, and then describe the mechanism of action and monitoring parameters for the new ITP drug fostamatinib. So let's get started with an overview of ITP. Some of the old names that you might be familiar with are idiopathic thrombocytopenia purpura or immune thrombocytopenia purpura, but today the proper terminology is immune thrombocytopenia. The pathogenic mechanism behind ITP is quite complex and multifactorial in nature, and so you have the secretion of antiplatelet antibodies by autoreactive B cells. You also have impairment of megakaryocytopoiesis or platelet production, and T cell mediated destruction of platelets via your cytotoxic CD8 T cells and regulatory T cells. Immune thrombocytopenia is a common hematological disorder that is characterized by an autoimmune process that causes the destruction of platelets and impaired megakaryocytopoiesis. In ITP, there's some component of the immune system that's gone awry, and the body is now seeing these platelets as foreign. So as you can see here in the middle of the slide, this glycoprotein peptide GP2B3A, which is usually found on the platelet surface, is being used to activate B cells, which makes antibodies against that glycoprotein. And these are mainly IgG antibodies that are made, but can be IgA or IgM. These antibodies go and attack the platelets, marking them for destruction by macrophages and other phagocytes that bear the Fc gamma receptor. Once bound, spleen tyrosine kinase or SYK allows the phagocyte to undergo SYK dependent mediated phagocytosis to clear them from the body. This mainly occurs in the spleen but can also be in the liver and in the bloodstream. Once engulfed, the platelet is destroyed and the macrophage expresses the platelet epitopes on the surface, which then are presented to CD4 T cells that are then able to amplify the destruction of these platelets as it activates more B cells to continue to make antibodies against the body's own platelets. The cellular immune response is also affected in patients with ITP as T regulatory cells and B regulatory cells are decreased and lose their function in regulation in this process, leading to more antibody production from the activated B cells. Another known part of the cellular immune response mechanism in ITP is platelet or megakaryocyte lysis via the cytotoxic CD8 T cells located in the upper right-hand corner of the slide. And these play a part in the downregulation of regulatory T cells. It's these cytotoxic T cells that also bind to activated macrophages and induce apoptosis of platelets or megakaryocytes. One last mechanism that I would like to discuss is impaired megakaryocytopoiesis, in which you have thrombopoietin, which is a liver-derived glycoprotein hormone that is regulating thrombopoiesis, and this normally binds to platelets in the blood where it's rapidly internalized and degraded. And so it's this level of unbound TPO in the blood that maintains platelet homeostasis. When platelets become high in the blood, more TPO is bound and degraded, leaving less TPO able to stimulate megakaryocytes, leading to decreased platelet production. And the opposite is true for when you have low platelet counts. In ITP, antibodies are marking platelets for destruction, but before the platelets and megakaryocytes are destroyed, they bind and degrade TPO, resulting in this relative TPO deficiency. When you're TPO deficient, you have less TPO able to stimulate megakaryocytes, and therefore low levels of platelets are seen. ITP, as I said, is a common autoimmune disorder that affects around 4 in 100,000 adults in the world. It also affects children and pregnant women, but this goes beyond the scope of what will be discussed today. ITP is characterized by damaged or reduced production of platelets that are involved in the clotting response, which can lead to significant bleeding events, although these are rare. But This largely affects the patient's quality of life, as patients are worried most of the time. ITP is defined as a platelet count of less than 100,000 without anemia, leukopenia, or other obvious cause of thrombocytopenia. And we'll see in a few slides just how ITP is diagnosed. There are two main causes of immune thrombocytopenia, primary and secondary. In primary, it is an unknown cause, but this accounts for the majority of what we see, and up to 80% of patients have primary immune thrombocytopenia. In secondary, it is commonly caused by autoimmune diseases and viral infections such as HIV or lupus, as well as those listed there. There are a few definitions that I'd like to go over before we get too far along in the presentation. Newly diagnosed, according to guidelines, is defined as less than 3 months, chronic being greater than 12 months, and persistent right in between those. Severe is defined as any clinical relevant bleeding, and then we'll discuss refractory in response in subsequent slides. ITP patients can present asymptomatically, but here are a list of common signs and symptoms of a symptomatic patient. As you can see, most of them do relate to the low platelet counts that are seen, with easy bleeding or bruising that's hard to control. The diagnosis of ITP is one of exclusion. So there's no standard test for the diagnosis of ITP. Thus, a history and physical, as well as getting the patient's drug history, is really vital here. A complete blood cell count with a peripheral smear is also very important, as we'll get into in subsequent slides for the diagnosis. And then HIV and HCV testing are also important to rule out those secondary causes. A bone marrow evaluation can be helpful in some clinical settings. Guidelines say that it is not necessary, but recommend further investigation with a bone marrow evaluation if there are other abnormalities found in this peripheral blood smear. Looking at the laboratory testing, this slide is here for your reference to see and look at the extensive workup that is involved in the diagnosis of ITP, in which you'll need a good peripheral blood smear. And as we've discussed, ITP is a diagnosis of exclusion, and so we're going to be focusing on isolated thrombocytopenia here. Once you exclude everything else and end up with isolated thrombocytopenia based on your smear, you can order these additional tests and really use the patient's history to determine if it is a primary or secondary cause. In secondary, the treatment involves removal of the offending agent or treatment of the underlying cause. Let's look at self-assessment question number 1. What are the common signs and symptoms of immune thrombocytopenia? Select all that apply. The correct answer is 1. Nosebleeds, 3. Prolonged bleeding that is difficult to stop, and 4. Purpura. Headaches are not commonly seen in patients with immune thrombocytopenia. Let's look at a patient case. JM is a 53-year-old male who moved here from California in 2014. In 2008, he was diagnosed with immune thrombocytopenia after presenting with thrombocytopenia, symptoms of dizziness, and a platelet count of around 2,000. His medical history is significant for chronic back pain, chronic neutrophilic leukocytosis, squamous cell carcinoma of the right sideburn zygoma status post-excision, as well as his original ITP diagnosis. He is a current everyday smoker. His past medical history is listed here, but one of the things I wanted to point out is what he's receiving for his ITP. And so he's currently receiving prednisone 60 milligrams orally daily, but is also on Bactrim DS for prophylaxis post-splenectomy. This is also because of his immunosuppression from his long-term corticosteroids. Recently, his disease has become more concerning, as he's experienced 3 hospitalizations in the past 4 months due to some severe musculoskeletal as well as abdominal pain. Unfortunately, the patient hasn't been able to locate his records from California, and so much of the information that we have is from his memory of it up until 2014 when he moved here to Colorado. Looking at his workup for his ITP, we don't know the laboratory values at the time of initial diagnosis, but what we do know is that in 2008 he underwent a splenectomy, and according to guidelines, because he was continuing to need treatment after, he's now considered to have refractory disease. In 2010, he underwent a bone marrow biopsy, which according to the ASH guidelines, bone marrow biopsies are not necessary, but may be informative in those patients of older age, those experiencing systemic symptoms, and those with an abnormal CBC with a peripheral blood smear. So per the guidelines, it doesn't appear as though he was a candidate, but if you recall, the patient has neutrophilic leukocytosis, so they might have wanted to do a bone marrow biopsy on him because of that. In 2014, the patient underwent a liver and spleen study, but there are unknown details on what these studies were due to his lack of records. Let's look at the treatment for ITP. The treatment of primary immune thrombocytopenia is listed here, and we'll talk about the majority of these therapies. But the thing I wanted to point out is the goal of treatment is just achieving a platelet count that prevents major bleeding for these patients. And so those that get treated are the newly diagnosed patients who have a platelet count of less than 30. And the decision to treat is really based on the patient's severity of bleeding, their bleeding risk factors such as hypertension, age, their activity level, as well as likely side effects from the treatment and their preference. There is no official order of treatment, but some recommended first-line agents. Corticosteroids being one of them, and they're still the mainstay of treatment per the guidelines. Corticosteroids impair the clearance of antibody-coated platelets by tissue macrophages. They also inhibit antibody production and increase platelet production, possibly by inhibiting phagocytosis of platelets by bone marrow macrophages. Dosing is listed here, and guidelines do recommend prednisone, but recent data that is not included in the guidelines is favoring use of high-dose dexamethasone because of two reasons. So it's shown a quicker response in patients' platelet counts as well as being associated with less adverse effects. Time to peak is a wide range of 4 to 28 days, and guidelines do recommend giving with IVIG if rapid platelet response is warranted due to their severity of disease. Failure of therapy would be considered if the patient is unresponsive to treatment or has relapsed after a given treatment. Per the guidelines, the definition of response is a platelet count of greater than 30 and greater than a twofold increase in platelet count from baseline on 2 occasions greater than 7 days apart. And this is accounting for all treatments that we'll be discussing today. IVIG is also one of the first-line agents for ITP, and the mechanism is very multifactorial in nature, as you can see here by the depiction on the left-hand side of the slide. But the mechanism in ITP involves the impairment of the clearance of these opsonized antibody-coated platelets, and also it plays a role in decreasing autoantibody synthesis. The dosing here is 1 gram per kilogram for 1 dose, and this can be repeated if necessary. As you can see, the time to peak response is very quick, 2 to 7 days, and so if you're really wanting to see an increase in platelet count quickly, this would be one of your go-to agents. Rituximab is a chimeric monoclonal CD20 antibody that depletes B cells, leading to apoptosis, which leads to a reduction in antiplatelet antibodies. Guidelines currently recommend Rituxan as a second-line treatment at a dose of 375 milligrams per meter squared IV once weekly for 4 doses. However, more recent studies have been looking at the drug in the frontline setting alone or in combination at the doses listed here. Peak response is 14 to 180 days, so quite a bit longer than the previous 2 treatments that we've looked at. Looking at our patient case quick, in 2008, he presented with these symptoms of thrombocytopenia, a platelet count of 2,000, as well as dizziness, and he was started on prednisone, 60 milligrams daily, and Rituxan at an unknown dose, and we also don't know how long he was on this therapy. There are some additional therapy options that are considered in the guidelines, such as a splenectomy, so that physical removal of the primary site of platelet destruction. The spleen, being the largest lymphatic organ in the body, acts as such to maintain a healthy immune system through, quote, cleaning the blood. In ITP, platelets are opsonized by autoantibodies, thus the body has marked them as foreign. These macrophages within the spleen engulf the opsonized platelets in an attempt to clean up the blood and thus are removed from circulation. But the spleen is not the only site that this occurs. It is the major site of platelet destruction, but it can occur in the liver and bloodstream as well. Guidelines currently recommend splenectomies for patients who have failed corticosteroid therapy, although patients can still see recurrent disease after a splenectomy, thus through accessory spleen, but also more commonly through autoantibodies remaining through the circulation. Treatment is indicated for ITP after a splenectomy if patients have failed or relapsed, but only if the patient is symptomatic or if they have a platelet count of less than 30. Splenectomy is very effective. However, studies have shown significant risks and caution should be used if it is done. Risks such as an infection, thrombosis, as well as pulmonary hypertension are common in this setting. Hence, looking for non-surgical options is really vital for this disease state. Thrombopoietin receptor agonist, romiplastim, Nplate, or mTrumplobag, Promacta can be used in splenectomized or non-splenectomized patients. Their mechanism is that they bind to thrombopoietin receptors on megakaryocytes to stimulate megakaryocyte maturation and platelet production through the JAK and STAT pathways. Dosing is listed here for your review. As you can see, Nplate is 1 microgram per kilogram subcutaneously, and higher dosing of Nplate has been used for severe treatment of immune thrombocytopenia at the 3 microgram per kilogram subcutaneous doses, and it's been shown to be safe and effective in these patients with steroid-resistant or treatment-refractory ITP before splenectomy for quicker responses. Promacta dosing in ITP is 50 milligrams orally once daily. Going back to our patient, in 2008, according to the patient, he failed Rituxan therapy. He also underwent a splenectomy in hopes of cure, but unfortunately it did not cure him. They tried transfusions to increase his counts, but it ultimately did not help, and so the patient was started on Nplate, and he saw a response, although we don't know what this response was. But the side effects for him were not tolerable, and so it was discontinued. Self-assessment question number 2. According to the American Society of Hematology guidelines, which of the following is recommended as first-line treatment for immune thrombocytopenia? Select all that apply. The correct answer is IVIG, dexamethasone PO, and Rho-D immune globulin. B, C, and D are correct as they are recommended to be first line per the ASH guidelines. This is an overview of what we've went through so far and what the patient has gotten. And so he's gotten first line therapy of corticosteroids. He's also tried splenectomy, thrombopoietin receptor agonist, and rituximab. Danazol is also another possible agent for these patients. The mechanism of danazol for the treatment of ITP is still largely unknown. It is an attenuated androgen that interferes with platelet clearance. Animal studies have suggested that it reduces the antibody secretion by enhancing the function of suppressor cells. Danazol also suppresses macrophage activity and may mediate its clinical effects, at least in part by decreasing the number of Fc receptors. Dosing is 200 milligrams orally twice daily to 4 times daily. Time to peak response is 28 to 180 days, so one of the longer treatments that we'll see here. Going back to our patient case, in 2014, the patient underwent a liver and spleen study to assess for any accessory spleen, but none was found. Later in the year, the patient was started on prednisone 80 milligrams daily, and the next month was started on danazol. In 2016, the patient was tried on IVIG or Gamunex at a dose of 400 milligrams per kilogram since his platelets were at 11,000. This dosing of Gamunex is suboptimal according to the guidelines, which, if you recall, is 1 gram per kilogram as a one-time dose. In 2017, the patient was restarted on Nplate at a dose of 1 microgram per kilogram once weekly, and the patient experienced a good response to treatment with platelets increasing over 24,000. The doses were titrated upwards, as you can see here from the chart. At the time of his treatment, his platelets were 6,000 and doses were gradually increased, with platelets showing a variable response. Starting in July of this year, the patient was admitted to the hospital for muscle aches and abdominal pain. He was also admitted in September and in October. In October, the patient finally refused further treatment with Nplate, and fostamatinib was recommended to be started in him. His current CBC is listed there. As you can see, his platelets are around 6,000. The patient has now been tried on danazol as well as IVIG. And there's still some other treatment options that can be tried, but let's look at fostamatinib, the new drug for ITP. Fostamatinib was FDA approved in April of 2018 via 2 parallel phase 3 randomized double-blind placebo-controlled trials that looked at 150 patients with persistent or chronic ITP who was seeing an insufficient response to previous treatment. Patients were assigned to receive fostamatinib at a dose of 100 milligrams orally twice daily or matching placebo. The median age was 54 years, 93% were white, and there was an even distribution of splenectomized versus non-splenectomized patients. Patients were included in the study if they were older than 18 years of age with primary ITP for at least 3 months. They had to have an average platelet count of less than 30,000 based on 3 qualifying accounts within 3 months preceding the study. Patients were excluded based on numerous criteria, but 2 I thought were important were arterial or DVT within 6 months, as well as uncontrolled hypertension. Efficacy, they looked at a stable platelet response by week 24, which they defined as a platelet count of greater than 50,000 on at least 4 of the 6 clinic visits, and this occurred within 43% of patients on fostamatinib within 15 days. 83% ended up responding within 8 weeks. Patients also experienced clinically significant benefits from this medication based on decreased bleeding events as well as decreased need for rescue medication. Safety, the most common adverse effects were diarrhea, hypertension, nausea, dizziness, as well as ALT increase. Patients also on fostamatinib experienced more infections. Fostamatinib is an oral prodrug that selectively inhibits spleen tyrosine kinase, or SYK, to reduce platelet destruction. In the making of this drug, the makers originally made R406 as a specific inhibitor of SYK. However, because of the low aqueous solubility of the drug company made fostamatinib, designed as a prodrug to be cleaved by alkaline phosphatases in the intestine. Let's get into the mechanism of how this drug works exactly. So as we briefly touched on at the beginning of the presentation, autoantibody-coated platelets bind to the Fc gamma receptor located on the antigen-presenting cells such as this macrophage in this depiction on the left-hand slide. Upon binding, SYK initiates the downstream signaling to start the process of phagocytosis, and this involves the cytoskeletal rearrangement. SYK is an important component of the making of the cytoskeleton and how it works correctly for phagocytosis to occur. Studies involving macrophages derived from SYK knockout mice were defective in phagocytosis of the Fc gamma receptor particles and in the signaling events. It is through the inhibition of SYK that thrombocytopenic protective effects were found in these murine models. Fostamatinib, as you can see on the right-hand side of the depiction, selectively binds to SYK within the phagocytes, which inhibits the downstream signaling and cytoskeletal rearrangement and prevents the phagocytosis of the antibody-coated platelet. It's because of this that the platelet is not able to be destroyed, and thus the platelets are spared, leading to an increase in platelet count. The dosing of fostamatinib is 100 milligrams orally twice daily. It can be with or without food. There should be no changes to the dosing made within the first month, but after 4 weeks, you can increase to 150 milligrams twice daily to achieve that platelet count of greater than 50 and to reduce the risk of bleeding. Common side effects are listed there, similar to this study, being diarrhea, hypertension, and those LFT increases. Some warnings and precautions that go along with fostamatinib are hypertension, and this is suspected to be due to the VEGFR2. It's a second target of the drug and has been thought to be a possible mechanism for the hypertension that's been associated with the drug. Treatment of Tavalisse-associated hypertension should be treated according to the hypertension guidelines. Due to hepatotoxicity risks with the drug, caution should be taken if patient has elevations. And below are the package insert recommendations based on the severity of elevation, and the dosing adjustments are listed there for you. Diarrhea is also common with this drug. Up to 31% of the patients in the clinical trial had diarrhea. Most patients, though, have been able to continue treatment just with supportive measures. Neutropenia, despite it not being common, does need to be monitored for, as well as monitoring for infection, since this drug does alter normal phagocytosis. And then this drug can also cause fetal harm, and females must verify pregnancy status prior to initiating Tavalisse. Females should also be advised to use effective contraception during treatment and for at least 1 month after the last dose. Monitoring for fostamatinib involves blood pressure every 2 weeks until stable, and then monthly. Liver function tests, CBC with platelets, and then absolute neutrophil count should be assessed monthly, and then assessment of signs and symptoms of diarrhea and hepatotoxicity should also be done. Fostamatinib does come as a 100 milligram film-coated tablet as well as a 150 milligram film-coated tablet. These can be taken with or without food, but patients should avoid taking it with a high-fat meal as it has shown to increase the AUC. There are some drug interactions to be aware of. So CYP3A4 drugs, specifically inhibitors and inducers of CYP3A4, can increase or reduce the exposure of Tavalisse in the body. The substrate drugs of CYP3A4 can also increase the concentrations of those other drugs. BCRP, or breast cancer resistant protein substrate drugs, can increase concentrations of other drugs, some common ones being rosuvastatin, topotecan, glyburide, and doxorubicin. So it's a mixture of chemotherapeutic agents as well as non-chemo agents. P-glycoprotein substrates are also a drug interaction, so digoxin can increase the concentration of substrate drugs. The cost right now of Tavalisse is $189 per tablet. Looking back at our patient case, JM has been approved for treatment with fostamatinib and will receive his first dose tentatively before Thanksgiving. He's already met his deductible for the year, and so he will pay $0 out of pocket for this medication, and he'll receive the standard dose of 100 milligrams twice daily for at least 4 weeks. The last self-assessment question here: what kind of drug is fostamatinib? The correct answer is A, an oral spleen tyrosine kinase inhibitor. I have also listed other treatments for completeness here. Some are older therapies that have been used, such as the vinca alkaloids. The mechanism of action and ITP for these are still largely unknown, but is speculated to be related to the inhibition of phagocytic cell function, as these agents bind to platelet microtubules. The dosing is listed there for your review, and as you can see, the time to peak response is 7 to 42 days. Rho-D immune globulin, or WIN-Rho, is also been used. The mechanism behind this is the sparing of platelets, as Rho-D is a synthetic antibody that binds to Fc receptors, and so this blocks the ability of the system to clear antibody-coated platelets. The dosing is 50 micrograms per kilogram, and this can be as a single injection or as 2 divided doses, and I just want to bring this dosing to your attention as it's 50 micrograms per kilogram, and based on a 70 kilogram patient, we would need around 12 vials of what we currently carry here at the hospital, which is the 1,500 unit per 1.3 milliliter vial. So just keeping that in mind, as it does come in larger vial sizes. Time to peak is similar to IVIG in that it's fairly quick time to peak response of 3 to 7 days, but the downside of using this medication is that it's been associated with a poor duration of response, so patients aren't seeing these benefits long term. It also has stipulations to its use, as patients have to be Rh positive to use, as well as have a negative DAT test and not undergone a splenectomy. This picture is here just as an overview of all the treatments discussed today. And then this is also an overview of the treatment response times and also the approximate response rates. So as you can see from the chart, fostamatinib is somewhat middle of the road when comparing time to peak response. And also, in the middle here with approximate response times. One other thing that I'd like to point out is that rituximab is 40 to 60% response rate, but long term, after 1 year, it's reported to be around 18 to 35%. Looking back one more time at our patient case, so JM has tried and failed steroids, Rituxan, IVIG, splenectomy, Promacta, and Nplate. His plan is to start Tavalisse in the upcoming weeks, but if the patient fails Tavalisse, there are just a couple options that are left to try. And so the patient can try vincristine vinblastine. Unfortunately, they cannot try Winro as it was not given before splenectomy, and that's one of its stipulations. But the patient could try combination therapy with dexamethasone, Rituxan, plus or minus IVIG. All of these agents have been tried for him individually in the past, but not together, and also it's been many years since they've been tried. Other options included in the guidelines are azathioprine, mycophenolate, as well as cyclophosphamide, and these could be tried in this patient. If you have any questions regarding this presentation, please feel free to contact me. And thanks so much for listening.